I'm Gemma. I'm one of the EverQ content authors, and I'm a Master of Philosophy student at Sydney University. And my research is looking at the experience of survival following allogenic bone marrow transplant in New South Wales. And this talk in particular is about secondary cancers. So I am just going to hopefully briefly go through the background, introduce you to the problem, tell you what we did, what we found out, and let you know what we think the implications are. So, why do we do allogenic BMT? Allogenic BMT is an uncommon but well-established treatment for many malignant and non-malignant diseases in both adults and children. This graph is from the European Bone Marrow Transplant Recipient Registry, and it shows the same thing that happens the world over. The majority of transplants are performed for the acute leukemias. Up to 40,000 are performed worldwide annually, and in New South Wales we perform majority of the near 500 transplants undertaken every year in Australia. This graph is a little closer to home, and it's from the Australasian Bone Marrow Transplant Recipient Registry, and it shows the increase in transplant transplant types over the past 6 years in Australia and New Zealand. This increase in activity, which is replicated the world over, is attributed to the increase in frequency of BMT relative to the population over time, to expanding indications for BMT, and to the growth of unrelated donor databases and the adoption of reduced intensity conditioning. It means that generally, patients who previously would never have been eligible for transplant, so those that are sicker and older, are now routinely undergoing the procedure. So this leads us on to survival. And while BMT has significant risks, the advances that have been achieved over the past 2 decades in patient and donor selection, management of acute toxicities, and in supportive care have significantly improved outcomes following transplant. So overall survival rates in general terms is excellent, with both adults and children, with most children having a BMT surviving into adulthood, and many adult BMT recipients surviving long term. So we have increasing indications for BMT, we have more people undergoing BMT, and we have more people surviving, which is obviously great. But the problem, the news is not all good, for as is the case with any major medical procedure, and as is the case with solid organ transplantation, survivors of BMT may experience significant long-term adverse effects of BMT that may impact upon the quantity and the quality of their life and the life of those around them. BMT does not guarantee cure, it just increases its possibilities. But as this list shows, if survivors are fortunate not to experience a relapse, then they have other major issues to contend with. The cumulative effects of the disease itself, of prior therapy, of conditioning chemoradiotherapy, of graft versus host disease prophylaxis, and of the complications of BMT and the treatments needed for those complications, all adversely impact upon every body system. Of this list of things, secondary cancers perhaps represent the most cruel of the late effects of BMT. The international literature tells us that survivors have a 12% cumulative incidence rate at 15 years post-BMT of suffering from a secondary cancer, and there is no known plateau. So in other words, the longer that a BMT survivor lives, the more likely they are to develop a secondary cancer. And all cancers have been found to occur. The identified risk factors for the higher rates of secondary cancer include a younger age at transplant, the use of total body irradiation, prolonged immunosuppression, graft versus host disease, or smoking prior to having the transplant. With regard to the recommendations, for almost a decade, international consensus guidelines for the care of long-term survivors have been available. These guidelines include recommendations for cancer screening, preventive health care and health promotion, specifically advising that survivors follow general population screening recommendations in their country for breast, cervical, skin, genital and bowel cancer, and avoid high-risk health behaviours. These guidelines also make clear that in patients with chronic graft versus host disease, additional attention needs to be paid to surveillance. So what are the general population guidelines in our country? I think we'd all be familiar with the Commonwealth government-funded national screening programs, which include Breast Screen Australia, the National Cervical Screening Australia and the National Bowel Cancer Screening Program. We know that these programs offer free screening to the Australian public at specific age and interval time points. And of course, the Cancer Institute, Cancer Australia and endless health-related organisations advocate 9 healthy lifestyle behaviours such as quitting smoking, being sun smart, being active, maintaining a healthy diet and limiting alcohol intake. Participation in these programs and health risk behaviour in Australian BMT survivors is largely unknown. So what did we do? What do we want? We wanted to find out about what our survivors in New South Wales are doing. So in this study, we aim to explore rates of screening for secondary cancers and cancer risk behaviour in an Australian cohort of allogenic BMT survivors and identify barriers to adherence with cancer screening recommendations. So what did we do? We did the largest study of BMT survivors in Australia. If you received an allogeneic bone marrow transplant between the years 2000 and 2012 in New South Wales, then we invited you to participate. This was a cross-sectional survey which utilised 7 questionnaires. The Sydney Post BMT survey consisted of 402 questions and divided into 20 sections. The questions included questions relating to secondary cancer diagnosis, cancer screening adherence, modifiable health lifestyle behaviour, together with demographic and social characteristics associated with barriers to uptake of cancer screening recommendations. And for each consenting participant, we collected data on their transplant procedure. So the results, in the study period, 1,475 procedures were performed. 55% of those patients were deceased or their status unknown. Of those that we could contact, or those that we had contact details for, we were unable to get a hold of 86 of those. 3% explicitly declined, and 125 people didn't return their survey. So in the end, we had a response rate of 66%, which we were really happy with, given that the survey took over an hour to complete. So who were our respondents? 57% were male. The median age at the time of survey was 54 years, and the median age at BMT was 49 years. 40% of survey respondents were 6 or more years after transplant, and the majority of patients resided in a major city, were of a middle or high income status, and were married or in a de facto relationship. Regarding the transplant procedure, the main indication was acute leukemia, and the majority of transplants were in CR1 or CR2. Sibling donors were the most common, and peripheral blood stem cells were the stem cell source of choice. Conditioning between myeloablative and non-myeloablative were fairly evenly matched, and T-cell depletion was used in over a quarter of procedures, and this all reflects current practices. So, the occurrence of secondary cancers. Nearly a quarter of our survivors had experienced a secondary cancer post-transplant. The most common was skin cancer, then oral cancer, and then a smattering of other types of cancer. And this is also consistent with international studies. With health behaviour post-transplant, we found that despite the intensive treatment the BMT survivors endure, they continue to engage in health risk behaviour. Smoking and drinking more than 14 standard drinks a week and not being sun smart were reported by 7.5, 7.7 and 22, nearly 23% of survivors respectively. 32% were overweight and 16% obese, and regular exercise, that being at least 3 times per week, was reported by 45% of survey respondents. Though I don't think we should be too critical here. In comparison to international studies and when comparing this data to Australian general population data, our BMT survivors are actually doing okay. The 2012 ABS data tells us that 16% of people smoke daily, 19.5% of adults consume more than 2 standard drinks per day, and 35% of Australians are overweight and 27% obese. With regard to activity, only a third of the Australian population are physically active. So with regard to cancer screening adherence post-transplant, our cohort had lower rates of screening for bowel, cervical and breast screening than previous studies in bone marrow transplant survivor populations. These rates are, however, similar to adherence rates among the general Australian population who participate in Breast Screen Australia, the National Cervical Screening Program, and the National Bowel Screening Program. Approximately half the cohort had had a skin check following transplant, and this is significant because while there was currently insufficient evidence to support population-based screening for skin cancer, and skin cancer screening is not recommended by major public health bodies, Australians experience a melanoma incidence rate 11 times that of the average world rate, and BMT recipients are at a markedly higher risk of developing skin cancer as a consequence of their cutaneous graft-versus-host disease and long-term use of immunosuppressive drugs and azole antifungal agents. So while in comparison the general Australian population, our survivors are doing well in trying to prevent and identify future cancers, the results of this study confirm that secondary cancers are commonly occurring after transplant, that high-risk health behaviour is still being engaged in, and that cancer screening is not being performed according to recommended BMT long-term follow-up guidelines. So this led us to ask questions about barriers to screening. When survivors... Oh, I wish it was there. Sorry. So when survivors responded negatively to attending screening, we gave them 4 options for why they had not done so. So nearly 5% reported they had not had enough time. Cost was reported to be an uptake in only very few survivors in our study. However, financial difficulties have been shown to impact cancer screening rates in other populations, and this may be a function of Australia's aforementioned free cancer screening programs. The barrier of cost was reported, however, for younger survivors who did not meet the age criteria for annual mammography. So for people who were under 25 or had had total body irradiation in their conditioning. Over a quarter of our respondents reported they did not feel it was necessary, and this suggests failures in the education and or the counselling of transplant recipients. But disturbingly, the overwhelming response was that it had not been advised by their treatment team. These explanations for low rates of adherence with cancer screening recommendations are also consistent with the literature that suggests that many factors act as barriers to optimal preventative care, including the lack of knowledge regarding the importance of cancer screening in both patients and providers, deficiencies in the organisation of preventative healthcare services, and scepticism regarding the value of screening. When we looked at factors which increased adherence to screening, the 2 major determinants were time from transplant and older age, contrary to other studies which have shown that being further out from transplant decreased adherence to preventative care practices. With the exception of cervical screening, all other cancer screening was significantly associated with older age. It is difficult, however, to know the significance of this finding, as there is no data regarding whether the age time points for the general population's cancer screening apply to BMT survivors, many who experience this increased risk from a younger age of secondary cancers. And the other factor that was correlated with an increased risk of the increased adherence to cancer screening in our cohort, for at least for men, was being in a relationship. And this is a finding that is broadly consistent with other cancer screening studies. Interestingly, our study found an association between participation in cancer screening and high quality of life. While this is reassuring to those involved in post-transplant care, it runs counter to recent literature that suggests that cancer screening can increase anxiety and overdiagnosis. There are at least 2 possible explanations for this, and the first is that those who have a high quality of life may be more motivated to maintain good health, or conversely, patients in participating in cancer prevention may confer quality of life and survival benefits. Now this is not working. It's nearly lunchtime, so I'm trying to hurry through. So, conclusions of my study are that in BMT survivors in New South Wales, secondary cancers are common. Health risk behaviour is generally better than the general Australian population, but cancer screening adherence is low for this high-risk group. So the implications of our study is that we think this data should be used to develop a model of care which is sustainable, cost-effective and consistent with patient care needs and preferences. Cancer screening needs to be embedded within BMT long-term follow-up programs, and this will hopefully reduce long-term morbidity and mortality related to transplant and improve quality of life. And that's just the acknowledgements of all the other people involved.
Thanks, Gemma. Very fast. Questions for Gemma? Do you think the non-focus on the risk of or the importance of lifestyle factors for any person with cancer, that the lack of disclosure about that is it's not necessarily unique to BMT?
Oh yeah, no, it's not unique. No,
because it's interesting. There was a webinar a few months ago that showed that if you're diagnosed with prostate cancer and you're a smoker, you're more likely to die of lung cancer than prostate cancer. And so I don't think people really get them. They think they've had their cancer now. So that's all of our practices. We're all going to go back and do better. So other questions for Gemma? Okay, thank you very much, and please join me in thanking all of our speakers as well as Gemma. Thank you.